think, yeah, 3 more minutes.
Sir, we are live now.
I think we can start. 2 more minutes.
2 more minutes, sir.
Yes. We can start, I think. It's 7 p.m. Yeah.
Okay, sir. Good evening, everyone. Myself, Mrs. Ramya Gayatri, Assistant Professor, Department of Pharmacy Practice, Chemist College of Pharmaceutical Sciences and Research. I welcome you all to the webinar hosted by Kerala Pharmacy Graduates Association, a platform to learn, share experience, and connect with experts in the field. The Kerala Pharmacy Graduate Association is a dynamic and forward-thinking organization that brings together the pharmacy graduates and professionals. KPGA plays a pivotal role in contributing to the overall development of the pharmacy sector by conducting a variety of activities like seminars, webinars, workshops, and conferences that address current issues and trends in pharmacy. Now, we are the part of one such program, webinar on evidence-based guidelines development, need of the hour. Evidence-based guidelines serves as a bridge between scientific research and clinical practice. These guidelines are designed to provide evidence-based recommendations and standards to guide clinical practice, healthcare policy, and decision-making. They are rooted in a systematic and rigorous process that incorporates the most current and reliable scientific evidence. These guidelines plays a fundamental role in improving the quality of care, enhancing patient outcomes, and ensuring that healthcare resources are used efficiently. The future of evidence-based guidelines in healthcare is likely to continue evolving and adapting to advances in technology, changes in healthcare delivery, and the increasing complexity of medical science. Respected fellow pharma community and participants from other streams, let's start with prayer song for seeking blessings from Almighty. I invite Ms. Namita, Associate Professor, Edutachan College of Pharmaceutical Sciences, Thiruvananthapuram, for the prayer song. Ma'am, please.
Maitri bhajata akhila hrijetri. Maitri bhajata akhila hrijetri. Atmavadeva paranapi pashyata. Atmavadeva paranapi pashyata. Yuddham tyajata spardham tyajata. Tyajata parishvarakramakramanam. Maitri bhajata akhila hrijetri. Maitri bhajata akhila hrijetri. Janani prithvi kamadukhaste. Janako devah sakala dayalu. Janako devah sakala dayalu. Damya dadatta tvayatvam janata. Shreyo ya sakala janaya. Shreyo ya sakala janaya. Maitri bhajata akhila hrijetri. Maitri bhajata akhila hrijetri.
Thank you, Namita Madam. It's my privilege to invite Dr. Sujit Verma K, Executive Member, Kerala Pharmacy Graduate Association, Principal, National College of Pharmacy, Kozhikode, for the welcome address. So please.
Thank you, Ramya. A warm good evening to all. We are here for the one-day webinar that is Evidence-Based Guidelines Development Need of the Hour. First of all, I'll come to my responsibility in inviting all to this particular program. Let me first welcome the dynamic person and the motivator, Dr. P.K. Srikumar sir, President KPGA, and he is a former Deputy Drug Controller, Government of Kerala. I welcome you, sir, to this program. Next, I welcome my dear student, Jisha Sarah John, who is a resource person today. She is the first student to complete the antimicrobial stewardship also. I welcome you, Jisha. Next, I welcome Professor Dr. Krishna Kumar sir, Executive Member, and as well as the Principal, St. James College of Pharmacy. Welcome you, sir. Next, I welcome Professor Dr. Shiji Kumar, Executive Member, also the Principal, Daleview College of Pharmacy. Mr. Rajesh, Executive Member and the Senior Manager, Pharmacy Operation, Maitra Hospital. Welcome you, Rajesh, sir. Next, I welcome Dr. Preja, Professor and Principal, Mar Diascore College of Pharmacy. Welcome you, madam. I welcome Ms. Namita, Ms. Ramya Gayatri, Noble Sakriya, all Next, I welcome all the participants and the eminent resource persons, eminent personalities in pharmacy fraternity. I welcome all of you to this particular program. Thank you.
Thank you, sir. Leadership is a combination of strategy and character. With great pleasure, I invite Dr. P.K. Sri Kumar, President, KPGA, former Deputy Drugs Controller of Kerala State, a trainer, spokesperson, dedicated counselor for pharma professionals on career guidance for the presidential address. So please.
Thank you, Ramya. Good evening to all. Our dear resource person, Dr. Disha, our executive member and moderator, Mr. Rajesh Thaleprambat, Professor Dr. Krishna Kumar, Dr. Sujit Verma, Professor Dr. Shiji Kumar, Professor Dr. Preja, Mrs. Namita, Mrs. Ramya Gayatri, Dr. Nobel Skaria, and Abdul Nasir, the General Secretary, and other dignitaries and dear professionals and fellow pharmacists. First of all, I thank, and students also. First of all, I thank Sri Rajesh Thaleprambat, who arranged this program utilizing the service of a great personality, Jusha ma'am, who will share her vast knowledge in the subject for all of us, especially those who are the clinical side, say PharmD and pharmacy practice sector. KPGA is arranging great programs for the last many years with a view to enrich our, future generation with power-packed knowledge, I should say, in their respective field. By seminars, big conferences like APC, activities on industry like, Pharmacity Project, career opportunities, related series of webinars and students funding, and many other competitions among the students, a community outreach programs by our women's wing, or as the association started its never-ending journey on 1976. Now we own a beautiful two-storied building in Trivandrum, and always we stand in front to guide and support the professionally support professionally to our fellow pharmacists and students. We have been a part of celebrations of Pharmacist Day very successful. And I would like to request you to support the association and the executive committee to materialize the great projects we are working for with strong and focused vision and mission. The subject for webinar is having much importance in the present scenario, and the experts in the field will definitely make the event colorful and most useful. You are now part of an honorable, tradition of healthcare professionals who have dedicated their lives to the betterment of society and the students, the future pharmacists. Let these type of well-designed and organized programs find the very result to empower we the pharmacists, and we can do more from all these kinds of activities. And it will help to build up our next generation pharmacists also. And the future pharmacists and experienced pharmacists will definitely shine on that. So thanking you once again, and wish all participants and the team all the best, and all the best for the webinar. Thank you so much.
Thank you, sir, for those inspirational words. Now, I request Professor Dr. K. Krishna Kumar, Executive Member, Kerala Pharmacy Graduate Association, Principal, St. James College of Pharmaceutical Sciences, Chalakudi, to address the gathering. So please.
Very good evening to one and all. Beloved, our President of KPGA, Dr. Sri Kumar sir, Secretary Nasir sir, and my colleagues of the various principals, Dr. Sujit Verma sir, Shiji Kumar sir, Preja madam, and the other dignitaries, especially the Rajesh sir, Noble and the most important of today's function, our resource person, and also our most important elements of today's function, the participants from various colleges. Of course, KPGA is doing so many activities. The president has already explained one by one, and I appreciate that KPGA is taking the initiative to arranging the different types of programs for the upliftment of our students. And here, of course, the Jisha is a clinical pharmacist, most experienced persons from a very reputed hospital, CMC, Vellore, with a lot of experiences. And she is having the Department of Infectious Control department. And of course, that everyone we know, even to the PharmD, the most important year is internship. Then after that, it is a skill development program. And with the experiences only, we are gaining the knowledge, especially the clinical aspects. So with Dr. Sujit Verma Saro explained, she is the first batch student of National College of Pharmacy. And from there, she has gained the experiences from the CMC Vellore. And of course, today's talk that will reflect her experiences and skillful approaches to our participants. So I take this opportunity to wish you all the best to every one of you. And also, I congratulate the KPGA for the initiation of taking the different types of activities, especially the useful for our budding pharmacists. Thank you.
Thank you, sir. Now, I invite Dr. Shijikumar PS, Executive Member, Kerala Pharmacy Graduate Association, Principal, the Daleview College of Pharmacy and Research, Thiruvananthapuram, for greeting the gathering. So please.
Thank you, Ramya. Respected President of today's webinar, Dr. P.K. Srikumar sir, Secretary Dr. Sri Abdul Nasir sir, Resource Person Dr. Jisha Sara John, Moderator Sri Rajesh Talamprathamu sir, our most respected Principal Dr. Krishnamurthy sir, Dr. Sujit sir, Dr. Kala ma'am, Dr. Prija ma'am, Dr. Noble Skaria, Dr. Mrs. Namida madam, Mrs. Ramya Gayatri, dear students and other distinguished audience, good evening to one and all. The topic is evidence-based guidelines development. Need of our is perfectly matching our current situation. We know these guidelines use a systematic reviews to critically appraise the information of the patient and the treatment schedule. This enhancing the safety, effectiveness, and quality of the treatment what we are offering to the patient. So we know that it is the time of artificial intelligence. So based on these guidelines, if it is possible to generate data, basically, suppose now 80% are asking for big data. Once they got a big data, they can create, they can correlate with the treatment plan, and we can implement a new process also based on these guidelines. I think so. In case of antibiotic resistance, we know well that antibiotic resistance nowadays the industries are not spending much money for the R&D activities because we are all the antibiotics are getting resistance by time being. So the importance of evidence-based guideline development is very crucial, and that is need of our actually that is the need of our this also this antibiotic resistance that issues also can be overcome by our this evidence-based guidelines treatment protocols. So in such a way, this webinar is going to be a very successful and very highly informative also. So I wish you all the best for this webinar, and I request the audience to make use of it. Enjoy the session. Thank you very much.
Thank you, sir. Now, I invite Dr. Noble Skaria, Head of Clinical Pharmacy, Apollo Adlex Hospital, Angamali, to give an overview of the topic. So please.
A warm good evening all. First of all, I thank KPGA for organizing this program. And as you all know, we are all moving into the evidence-based guidelines. We are all referring that. So in this current scenario, we need more data regarding the latest treatment guidelines and all. So in this here, Dr. Disha is one of the senior pharmacists in AM, and she is doing so many things in antimicrobial stewardship programs and all. And she's also is a guideline profession in WHO guideline. So these evidence-based guidelines are the recommendations for medical clinical practice that are developed using the best available scientific evidence. And these guidelines are typically created by expert panels or organizations and are informed by the systematic reviews of relevant research studies. And they aim to provide healthcare professionals with the up-to-date and reliable information to make informed decisions about the patient care. Following evidence-based guidelines can help improve the quality of healthcare and patient outcome. So in this section, Dr. Disha will be explaining the process that involved in making evidence-based guidelines and also the latest updates regarding the recent studies and all. So CMC Vellore is one of the best organizations conducting so many studies and all, and Dr. Disha is participating in this section. So I'm handing over to Dr. Rajesh and Dr. Disha for the section. Thank you.
Thank you, sir. Moving on to today's session. Today we have Mr. Rajesh Thalaparambatha to moderate our session. Mr. Rajesh completed his B.Pharm and M.Pharm from Sri Ramakrishna Institute of Paramedical Sciences, Coimbatore. He commenced his career as a pharmacy lecturer at JSS College of Pharmacy, Mysore in 1998. He also served in the Pharmacy Services Department at Saudi Aramco Medical Sciences Organization, now known as Johns Hopkins Aramco Healthcare. Mr. Rajesh also contributed as a member of the Pharmacy Quality Improvement Team, played as a senior role in the Pharmacy Advisory Council also. He is an active professional with different roles in patient safety initiatives, invited speaker for conferences including Indian Pharmaceutical Congress, etc. Since February 2023, Mr. Rajesh Thalaparambatha has taken over the position of Senior Manager, Pharmacy Operations at Maitra Hospitals, Kozhikode. With this short introduction, I invite Mr. Rajesh Thalaparambatha, Executive Member, Kerala Pharmacy Graduate Association, to moderate today's session. Welcome, sir.
Good evening, everyone.
Good evening, sir.
Am I audible?
Yeah, you are.
Okay. So my today's role is to moderate the program as well as to introduce Dr. Jisha Sarah John. She has chosen a beautiful topic for the day, which is evidence-based guideline development need for the hour. So actually the evidence-based guidelines, they are like crucial in healthcare as they provide foundation for therapy decisions coming from the scientific research and then the culture. By relying on rigorous evidence, healthcare practitioners can now offer the most effective treatment, improving patient outcomes and safety. Moreover, evidence-based guidelines promote consistency in care, reducing unnecessary variations and help allocated limited resources wisely, making them an indispensable tool for the modern healthcare delivery. In an era of rapidly advancing healthcare knowledge, these guidelines are compass that guides the clinicians towards best possible care for their patients. Now, let me take this opportunity to introduce Dr. Jisha Sarah John. Dr. Jisha Sarah John is a clinical pharmacist in the Department of Infectious Disease at Christian Medical College, Vellore. She is the first person to complete the fellowship in antimicrobial stewardship from Christian Medical College, Vellore, and currently the coordinator for the same course. She's a Cochrane author, evidence synthesis member in India COVID guidelines, WHO meningitis guidelines, and brain infection guidelines, India. She's one of the drafting member of the WHO Echinococcus guidelines. She finished her PharmD from National College of Pharmacy, Calicut, and MBA in Health Hospital Administration from Annamalai University, Chidambaram. She's interested in antimicrobial stewardship, systematic reviews, clinical trials, evidence synthesis, and guideline development. So welcome, Dr. Jisha Sarajan. The stage is yours now.
Thank you, Rajesh sir, for that overrated introduction. So I'm so happy for this platform so that I can share some of my knowledge which I have gained through my experience during CMC. So I'll start my presentation right away. Can someone make me a co-host or host?
Bobby sir?
Jenny?
Can we?
Jenny?
Yes, sir, done.
Oh,
He is already co-host. Yeah.
Yeah, please start.
Okay, thank you. So, is my slides are visible for you?
yes,
Yeah,
Jisha,
yeah.
please. You can display the first one. Yeah.
Madam, can you go to full screen? Yeah.
Yeah, I have. Okay. So my topic today is evidence-based guideline development need of the hour. One thing I can promise you is it's a very dry subject, and hope you won't need sleeping pills for today. So I don't have any financial disclosures. For the slides and all these things, I have to acknowledge Dr. Pratap Tarian, Emeritus Professor CMC Vellore, Dr. Joseph L. Matthew, Professor at HOT, PGI Chandigarh, and Dr. Priscilla Rubali, my mentor and head at Department of ID, CMC Vellore. So today, what all things which I want to cover for the day are, what is an evidence-based guideline, the process of development of an evidence-based guideline, and from this, the evidence to decision framework. So these are the three things which are the things which I would be discussing with you today. So the first question is, what is a clinical guideline? So clinical guidelines are systematically developed statements. They are a statement designed to help administrators, practitioners, and patients make decisions about appropriate healthcare for specific circumstances. So it's actually like designed to help to make a decision. It's not like you should do this or you should do that. It's like we recommend it, or we strongly recommend it, we conditionally recommend it. So it's kind of a statement that will help us to make informed decisions. So what is an evidence-based guideline? So in order to know that, the first thing we should know is what is not an evidence-based guideline. So first one is consensus statement. Consensus statement means two or multiple experts or people come together for discussing one particular topic, and they arrive at a conclusion, collective opinion suggestion of an expert panel. That is called a consensus statement. Then a position paper, that is a document that explains or advocates a certain course of action. That's a position paper. Then do's and don'ts, all these policies, guidelines, guidances, we can call it as guidelines, guidances. And then usual guidelines or recommendations. So these things are actually not considered as an evidence-based guideline. So this is an example of something that we have seen quite like 2 years back. This is something, it's a kind of like a position paper, which is like, what is the course of action that you should do if the patient is having a mild disease? What should you do? What if the moderate disease or the severe disease? So this is kind of a course of action. This we cannot actually say it as an evidence-based guideline. So, and this is an example for a consensus statement. And so next, what is an evidence-based guideline? So then evidence-based guidelines are systematically developed statements based on current based evidence containing recommendations to assist healthcare that means provider, patient, public, policymakers to make informed choices or decision. So it has certain methods to follow, and it will be based on evidences. What are all the clinical evidences? And it will contain recommendations, and that will help the healthcare provider for assisting the healthcare provider to make an informed choice. It's not like just blindly following something. It will help you to make an informed choice. So the recommendation, what do you mean by a recommendation? So it tells the intended guideline end user what he or she can or should do in a specific situation to achieve the best health outcome possible. So for say, one of our doubt usually, in a setting, let's say, should I use this? For example, like past 2 years back, we had this hydroxychloroquine drive. Everyone was behind HCQ. It will be preventing the development of COVID. So it has become a political issue. So we don't know whether it will give us a best to do right now. So the guideline, we don't have, at that point of time, what the problem was, we didn't have enough evidences. So whatever, all the statement, all the political hangama, whatever happened, it was all baseless. It was all evidenceless. So what a evidence-based guideline can provide you is, it offers a choice among different interventions or measures, whether to take HCQ, whether or not take HCQ. It offers a choice, positive impact on health implication for the use of resources. So how are we supposed to make a development of evidence-based guideline? How are we supposed to develop it? So the process of guideline development, administrative aspects as well as technical aspects are there. So first, the administrative aspect, is a guideline needed? First, our question should be whether we should make a guideline or not. The very first question, if the patient is hungry or not, should we give them water or not? So if we should give water, we should need a guideline for it. So if is it a normal patient or is it a renal restricted patient? So if it's a guideline needed for in the view of a nephrologist or a cardiologist, yeah, a guideline is needed. But in case of a normal, not so critical patient, is the guideline needed for such a patient? No, definitely not. So next one is a steering group. A steering group, and then scope and purpose, guideline development group is there, then declaration of interest as well as conflict of interest management, then decide questions, what all questions that are needed to be addressed in the particular guideline. All these things are needed, are addressed in the administrative aspects. Then there are the technical aspects. Technical aspects are like convert to PICO questions. What all questions, what are all the queries, what are the things that we are going to address in this particular guideline? We have to convert that into a PICO question. So can someone from the audience please tell me what do you mean by PICO? P-I-C-O. Anyone? Shout out. Okay. So then I'll tell that answer. It's like PICO is P-I-C-O. It means population, intervention, comparator, outcome. So whenever we actually have a question, it will be like a population, intervention, comparator, and outcome. So the question will be, for example, if we want to drink water in a renally impaired patient, that is the population, is drinking water, that is the intervention, or not drinking water, we are comparing it with without water for the best possible outcome. Or the outcomes we will be looking at will reduce mortality. Will it be reducing the death of the number of patients? Will it reduce the hospitalization numbers of the patients? So that is like a PICO question. It will have 4 aspects: PICO, population, intervention, comparator, as well as outcome. Next is systematic review. Systematic review, I have a detailed section for that. Then evidence appraisal also, then evidence to decision, draft recommendation, and the draft the whole guideline document. So this is all the process of the guideline development. And and disseminate the document as well as update it. So once it's not like once we made it and we just leave it like that. It's like every time when the new evidences are coming, we have to update the recommendations. So the first question is a guideline needed? For the problem which we are facing, should we need a guideline? If there is a problem, yeah, then we need a guideline. That is the thing. So then the steering group. Steering group is kind of like we know the stakeholders or the people or the eminent personalities who are actually guide the whole process. Like they will draft the scope, they will draft the key questions, they will oversee the whole process, and they will be the people who are drafting the recommendations, then oversee the people who are actually the controlling the whole process. That people are known as the steering group. Then scope and purpose of the guideline. So the purpose of the guideline will be what are all the objectives, what are all the questions. So for whom we are actually making the guideline, whether it is for policymakers, whether it is for clinicians, or is it for patients, or is it for general public, or we can also ask like for which country, for developed country or a low and middle income country, or is it for a developed nation, high income nation. So based on the population, based on for whom we are actually recommending this guideline, guidelines can change. Then the guideline development group. Guideline development group, as I was actually part of this guideline development group, and the subcommittee of this guideline development group will be the evidence synthesis team. So they have to examine the evidence, appraise the evidence quality, interpret the evidence, what are all the available evidence. Then based on that, the recommendations will be formulated. So that's the role of guideline development group. Then who should be in the guideline development group? Guideline development group will contain technical experts. Technical experts means methodologists. Methodologists means statisticians, the people who know the guideline development group, people who are experienced in the guideline. Yes. Representatives of the group, stakeholder. So if it is supposed to be for a, yes. Okay, so if it is supposed to be for a government purpose, then the end users will be part of this thing. So expert in
Participants, please mute your microphones.
Yeah, thank you. Then next one is like conflict of interest and conflict of interest and declaration of interest. Conflict of interest, like if we are in the part of this guideline development group, will the recommendations, the people who are in this guideline may or may not can what? Bias the recommendations. For example, like if we are actually a part of a something like a what should I say? Like a worm infestation. If we are actually making a recommendation for a worm infestation per se, okay. So some people would say, okay, we can actually clear it with a medicine itself. If there is actually a surgeon is there, he might say, okay, surgery is better than actually having pills on the patient. So the biases, the conflict of interest, the interest of the patient, and sometimes we may actually have stocks in particular company. So like per se, if a pharmaceutical companies actually have given out a new product, and whether we should include that product in the new guideline or not. If one of us is actually having, if one of the member in the guideline development group have some stocks invested in that particular company, then we may be biased. Like, okay, we may want that particular product to be included in the guideline. So this kind of conflict of interest are supposed to be declared before we are actually part of this guideline development. Then formulate the PICA questions. We have to make it into population, intervention, comparator, outcome, and sometimes time frame. Like if there is actually duration, or then if it is for inpatient, setting is actually if it is for inpatient or outpatient, like that. Settings are there. So we have to formulate the PICA question. Then after first making the PICA question, we will go for the systematic review of evidences. So what is systematic review? Systematic review are reviews of evidence relevant to a clearly formulated question. There will be a question that uses systematic and explicit method to identify, select, and critically appraise relevant research and to collect and analyze data from the studies that are included within the review. It's nothing I will say, but it's a systematic kind of methods that used to formulate the evidence. Let's see how we are actually doing the systematic review. So these are actually the hierarchy of scientific evidence. The weakest one are on the bottom of the pyramid. They are case reports, opinion papers, letters. Then goes the in vitro studies, cross-sectional studies, and the top of the pyramid is actually the meta-analysis as well as the systematic review of randomized as well as non-randomized controlled trials. So that is the hierarchy of scientific evidence. So in guideline development, systematic reviews are used to make informed decisions. So first we will frame the question, which I said we will make the PICA question. Then identifying relevant publications, assessing the quality of study, summarizing the evidence, interpreting the findings. That's actually the steps in a systematic review. Let's say first one, framing the question. So which I already said, for example, like is favipiravir effective in treating COVID-19? Favipiravir is an antiviral drug that was actually proposed to treat COVID-19. So the population is COVID-19, intervention is favipiravir, comparator is non-favipiravir, outcome is example like 7-day viral clearance. So how many patients have become PCR negative, and then 28 days mortality, like how many patients have been dead in the 28 days of the therapy, and then what are all the adverse effects that were actually happened in the patients during the treatment as well as the follow-up period. Then before conducting a before doing the systematic review, the first step is actually making a protocol. We have to make a protocol. We have to clearly define the questions, define the outcomes, all the steps that we are supposed to follow. We have to priorly we have to decide all those things. Sticking onto the protocol only we will be moving forward. So when we go for the evidence and when we see a lot of other questions, like in our protocol there is no provision for including patients having renal impairment. But when we actually see a lot of when we do the research, we have seen a lot of patients who are actually having renal failure. Then we may have to, then we will be having a second question: should we include the patients or should we not? But actually, if our protocol clearly says that we should not be including, then we have to exclude all those patients, all the studies that are actually having the renally impaired patients. So that's how we have to stick to the protocol when we actually are making a systematic review. Then the next one is identifying relevant publications. This is like we have to search the databases. Databases will be like we will be searching for case reports. That for, if we are sticking for randomized control trials only, we will be looking for PubMed, Epistemonicos, or Ovidem-base, or Cochrane Trial Registry for clinical trials. So all these databases we will be searching on, and then this the search will be like we will be actually without any language restrictions. We will be, even if the study is in German or something, we will actually include the study. We will extract the data. Then the study criteria shall flow directly from the review questions and the specified a priori. All the question, this search will be like, for example, I I would like to tell you how, for example, if we are looking for a search, we can't only say, for example, if we are searching for papers for meningitis. So sometimes if we search for just meningitis, all the papers may not be there. So sometimes we have to say meningoencephalitis too. So sometimes they may not mention both meningitis or meningoencephalitis. They will be only mentioning as encephalitis only. So all these words which are actually synonymous to each other, all these words we have to be incorporated so that we don't miss out any papers. Like that, we have to make a search strategy, and that's how we are actually identifying the relevant publications. And reasons for inclusion and exclusion. From the search, we have to actually select the particular studies that are actually fitting to our questions. Okay. Then assessing the study quality. Study quality assessment is usually be done by risk of bias tool. So for a randomized control trial, which I usually do is using a risk of ROB2 tool, so which is freely available in the Cochrane website. And for non-randomized studies, we can use Robinsci or Newcastle-Ottawa scale or Joanna-Briggs. JBI. So all this kind of tools are available to appraise the quality of studies which we are supposed to put into our evidence. So that will actually help in making a strong recommendation. So the fourth step is actually summarizing the evidence. So what we will do is we will extract the, after assessing the quality, we will extract data from all these papers, and we will pool all this data together. So that's how we will do summarizing the evidence. So this is actually for summarizing the evidences. Most of the time we will use something called a meta-analysis. Meta-analysis is actually like pooling the data from various studies. So this is such a meta-analysis. This graph is known as a forest plot. So in this forest plot, we can see each study, so this traffic light, this positive, negative kind of thing, that is actually showing the risk of bias of this particular study for this particular outcome. So this is actually a 28-day mortality for the Favipiravir systematic review, which I have done. Then next one is this is a forest plot, and the last diamond, this is the effect estimate. So this is the line of no effect, and if the diamond is actually crossing this line of no effect, that means the a drug is actually having no effect. I mean, like it is neither giving you any benefit nor it is making any harm. So like that, the diamond is actually the overall effect estimate. So the next one is actually the this is called the grade. This grade is actually we are assessing the quality of the evidence. So this will be, the recommendation shall be graded by referencing the tool which we usually use is Grade Pro GDT. Grade assessment tool is what we usually do. So the grade assessment, I'll like to take it in a bit more. So it will be like evaluate the quality in individual study. Evaluate the quality across studies for each outcome. For each outcome, we have to assess the quality. Then evaluate quality across outcomes to formulate a recommendation. So evaluate the quality across outcomes to formulate a recommendation. Next one is, so let's see how we are actually assessing the grade. So the pooled effect estimates for each clinically important outcome indicate appreciable advantages. First, we will see. We will see the 95% confidence interval. The confidence interval is actually the width of the diamond. I have shown you one diamond in the bottom of that forest plot. So the width of that is sometimes the diamond will be so wide that from one end to the other end. So that is actually, we will say the confluence of interval is so wide, we cannot actually make a decision from this particular data. So that will actually reduce the quality of the evidence. So how confident are we in this estimate? These estimates are likely to be true. These effects are likely to be seen in actual practice, that further research will not change these estimates. So all these things are actually, we will be coming for in the grading of the evidence. So a summary of findings table will be created. So we will be looking at the absolute differences, the absolute difference with intervention, without intervention. All these things will be coming under the grade quality. So the grade quality, how we will be assessing the grade quality is, we will be looking at risk of bias of individual studies. So each individual study, how it has affected the quality of the evidence. Then we will be looking at the indirectness, inconsistency. Inconsistency means the heterogeneity. I mean, like if the studies were actually in the same setting, I mean, like if there is any variation in the population that we have studied, or was there any differences in the dose we have used? Like if, for example, like if we are doing a study in the ceftriaxone, and the dose used, sometimes it will be like 1 gram OD and 1 gram, 2 gram BD. So these two studies will be, we cannot pool these two doses. So if we have pooled these doses, then there will be an inconsistency. The dose of the intervention was not the same, or the comparator was not the same, or sometimes another co-intervention was also part of this thing. So that can all cause an inconsistency in the that all can increase the inconsistency of the evidence, which will actually decrease the quality of the evidence. Then indirectness, if there was actually any differences in the population setting. Then imprecision. Imprecision is actually the width of the confidence of interval. Then another thing is actually the heterogeneity. Heterogeneity will be like when we actually pool the effect estimates, if the confidence of interval of two studies are entirely poles apart, it's like they are not even merging one over the other. It's like both of them are actually giving entirely different type of results. Then there is actually a heterogeneity in that particular evidence we have to see. So that will also reduce the quality of the evidence. So we also have to think whether these are actually large effects, or whether there are any or is it only a small effect, or is the contribution of this particular effects are whether they are large or very small. Then in non-randomized studies, we will have to check for things like confounders. So other, like for example, like if the aspirin have been started, and if there are more smokers in a particular group, smoking can actually increases the rate of heart attack in a person. So if we have started aspirin, and we will be looking at whether it has reduced the mortality or not. But if there is actually one group is actually having more smokers, that's actually a confounder. Okay, so the things should be equally distributed among the participants in the both arms. So that's how we will be looking at the various factors that actually increase or decrease the quality of the evidence. Then these are all about the inconsistency, imprecision, directness, all those things. And so finally, when study limitations, all these things we will be grading. We will be grading means if the risk of bias is too high, we will downgrade by 1 level. If the inconsistency is there, we will be downgrading. And if there is indirectness of the evidence, we will be downgrading by 1 level or 2 level. So if this downgrading will happen like that, the magnitude of effects will also be will be decreasing or increasing, and that will finally give us a certainty of the evidence, how sure we are about our evidences. So there are 4 levels. First one is high, which is actually there are no confounders. All the studies were having very low risk of bias. There were no inconsistencies, no heterogeneity. The confidence of interval was short. So in that cases, the certainty of our evidences will be very high. So, and if very small differences are there, then it will be moderate, then it will be low. In very low situation, we can say that we are very uncertain about the quality of the evidence. The quality of evidence is very low, and we are very uncertain whether the intervention is actually beneficial to the patient or not. So this is finally the summary of findings of a particular this is for the COVID-19 infection. This is the summary of findings table, death due to any cause. And we can see the certainty of evidence as high. So we have actually one or two intervention, the drug which we can be used up. So here the confidence of interval is 0.62, which means the drug actually reduces the mortality. So that means which drug we have used here is actually beneficial to the patient. So, and the certainty here is very high. So we can actually say that we are very certain that this particular drug will reduce the death. That's all. We have only reached up to that. We are certain that the drug will reduce the death. That doesn't make it as a recommendation. We will only say that it will reduce the death, and it will reduce the and then there is the next outcome, progression to mechanical ventilation. When we use this particular drug, whether the patient will go into ventilator or not. So the certainty is actually low, and we will be like, it may reduce. We are not sure, but it may reduce. It is a low chance. And then there is actually the third one is negative PCR, very low. And we will be saying like, we are uncertain that whether this drug will reduce the viral load in that particular patient. So that's the summary of findings table. This is our comments. This is how we will qualitatively appraise the evidences that are in our hands. So then finally, this rate of overall quality of evidences, we will be giving it to the panel, and this panel will finally decide and make the guideline develop. They will be the one who will make a recommendation. So let's see how they are actually making the recommendation. For the recommendation, there are actually like two kinds of recommendation: strong recommendation as well as conditional recommendation. Our evidences always need to be strong for a very high or low for making a strong or conditional recommendation. I'll tell you why. Because formulating a recommendation, we will be actually using a evidence to decision table. So these are the various things that actually will be leading. Till now we have made an evidence. We have seen what are all actually the things in our hand, the evidence, what are all the evidences that are available, is the evidence high quality or low quality. That's all what we are arriving at when we do a systematic review. After we have a systematic review with appraised quality of evidences, the next thing the panel will discuss on it. The panel will be discussing is the problem a priority? I mean, like, should we first make a recommendation? First, the PICO, each PICO for guidelines, there will be many PICOs, and this particular PICO, is it a priority? If it is a priority, yes, then go for the next question. How substantial are the desirable anticipated effects? So with this particular intervention, for example, per se, like with like hydroxychloroquine in COVID, okay, let's say take that example. So what are the desirable effects with the use of hydroxychloroquine in COVID-19 patients, whether the mortality, where there is any mortality benefits, or whether the viral load has been cleared. So all these are the desirable effects. We will be looking at the desirable effects, and we'll say, and then we will be looking at the undesirable effects. Then what is the certainty of the evidence? What is the certainty of evidence that we have currently got at? Then value main outcomes, a variability in how people value the main outcomes. Then next comes the stakeholders. So for whom we have actually are going to create this particular guideline. So if it is going for the population, people, then will they be welcoming this particular recommendation? Then does balance between desirable and undesirable effects? Is there a balance? Then what is the cost of this particular intervention? If we are going to implement this particular intervention, is it going to be worthy or not? For example, I can say you one example. There is a drug called casirivimab imdevimab. Then we would call it as Regeneron. So this Regeneron is having high quality of evidence that it actually reduces the severity of this particular disease. But the thing is, for one vial, for this drug actually costs 1.5 lakhs rupees. So our question will be whether we should recommend it or not. Because with 1.5 lakh rupees, we don't know whether we will be actually reducing the progression of disease in this particular patient. So cost is actually a factor. And then certainty of the resources or cost. Do we have ample of evidences that this much of, that is actually the cost benefit ratio. We will usually say that we will be choosing a drug based on the cost benefit ratio. That is actually the implication here. Then does the cost effectiveness favor the intervention? What would be the health equity? Health equity is something that whether we can actually implement this thing in all of our population. So is the intervention acceptable to key stakeholders, for doctors, for nurses who are going to administer this drug? Okay, then there is actually a particular drug who is supposed to be, okay, we usually have the enema. I mean, like for the treatment of Crohn's disease. We can say that enema will be, retention enema is going to be very effective. But is it acceptable to the patient? Patient will be more relying on a capsule or a tablet, or they may even accept an injection, but for every day, will they be accepting for a retention enema? So this kind of acceptability, all these things will come into play before we make this evidence into a recommendation. So let's see in detail. So is there a priority? This is actually the grade evidence to decision framework. WHO also has adopted the same thing only. So judgment, this is the problem, a priority, then how to decide this burden, consequences, impact. So with this disease, how many deaths are going to be there? So for example, let's say common fever, flu. So is there going to be, and there is actually myocardial infarction. So which is going to be the more burden thing? So if it is a myocardial infarction, when it comes, the patient will be, there are 50% chances that the patient will be dying. But with a common flu, how many chances are there that the patient is going to be dying? So is that a problem? Is the problem a priority? Should we go for a guideline recommendation? That's the thing that we will be looking at. Then desirable effects. Is it trivial or with varies, or do we have a large desirable effects? Then the next question is, do we have undesirable effects? Is it undesirable effects are large or moderate? Then the next question is the certainty of the evidence. If the evidence that we currently have, is it very high, moderate, low, or very low, or didn't we get any evidence or not? So all these provisions are there. This is the ETD, evidence to decision template. Then next one is the value about how I already explained it. Is there important and unnecessary about variability in how much people value the main outcomes? If the patient is actually having a death or a progression to the ventilator, or if the patient is actually having adverse effect, we are looking at the adverse effects. Sometimes very minute adverse effects like hyperuricemia or something, maybe a muscle pain will be there, but for sometimes it will be like a high adverse event like bleeding or a platelet reduction, something like that. So we have to value what are the various the outcomes which we have selected for this particular recommendation. Is it acceptable among the population. Then balance of effects. Balance of effects means if the positive, is the desirable effects are more than the undesirable effects. So that's the favors the that's the thing that we will be looking at, the balance of effects. Then resource required. So for resource required, I would like to quote an example. In one of the African, we have this malaria drug. For malaria, artesunate as well as chloroquine. People have compared with between artesunate as well as chloroquine, and they have found that there is a huge mortality benefit when we use artesunate, and the quality of evidence is quite okay. But the when the stakeholders, when they have taken this thing, when they discussed it, the cost for implementing artesunate in a public health setting is very high compared to the chloroquine. So when we use chloroquine, we can actually prevent. When we use artesunate, we can prevent deaths. We can prevent deaths. But if we use chloroquine, we can prevent only 5 deaths among 10 patients. But the cost to implement this particular artesunate, this is a poor African country. They don't have that much of funds. So what they choose? They choose to use chloroquine so that they can actually prevent, at least prevent 5 in 10 deaths, rather than implementing artesunate, which they cannot afford at all. So the next thing is certainty of evidence, that we have actually, is there any evidence for this particular cost? So for that, we actually need cost-effective studies, cost-effective analysis. Sometimes we use the number needed to treat, number need to harm, to assess all these things. But most of the time, we will be having no included studies. Most of the time, we won't get any studies that are actually comparing the cost-effective or cost-benefit things. Then equity. Equity is like, can we give it to all the patients, to all the people in the social strata, to all the people available? So equity is something we can actually think about. Then acceptability, as I already said about in case of the retention enema among the stakeholders. Then feasibility. Feasibility is something like, if the particular drug is actually supposed to be in somewhere in another country, there is no production of that drug in our place. So in that case, it is very unfeasible, like to particularly recommend that kind of an intervention. So that's about the feasibility. And so finally, after discussing all those things, we will have a summary of judgment table. This is the summary of ETD table. We usually call it as a ETD table. So this is what it will be looking like. Balance of effect. What we will be looking at the summary of judgments. Then we will be recommending. We are strongly recommending against the intervention, or conditionally recommending against the intervention. We may either recommend or not. Then we will conditionally for the recommendation, or we strongly recommend the intervention. We can do any of these things. So then that's about the recommendation part. So then after this we will be drafting the recommendation, then justification. We will be justifying what are we actually why we have actually made this particular kind of recommendation. Then subgroup consideration. Subgroups are like for particular renally impaired patients, we are actually doing this thing, or for liver impairment patients, we are recommending it or not, or other kind of for pregnant ladies. These are all subgroups. Or for aged population, or for pediatric population, all these are like subgroup consideration. With general recommendation, we may sometimes have subgroup recommendations too. Then implementation considerations. What are all the various factors that we actually need to? So these are all the things that will come in the document. Then monitoring and evaluation. So for this particular guideline, how it is going to be evaluated among the public. Then we will be looking at the research priorities. What are all the, after when we have gone through all this guideline development process, what are the things that the guideline development group has felt about what is the next research priority should be. So everyone should be focusing on one thing. So the focus of our research should be shifted to some other place. That all will come into light when we actually make a guideline. So that it will be reflecting in the updation for the next guideline. So that's all are the various steps for this evidence-based guideline. So I would also like to show one WHO guideline, which is actually how it is actually look like. So this is actually a guideline document for drug-resistant tuberculosis treatment. This is the latest 2022 update, and this is the okay. So this is the recommendation. This will actually be like WHO suggests the use of a 6-month treatment regimen composed of bedaquiline, pretomandad, and metoxoflan rather than the 9 months. So here we can actually say the PICO is actually MDR TB patient. Multi-drug resistant TB patients is actually the population. Intervention will be like bedaquiline, pretomandad, and linezolid, moxifloxacin for. It will be like for a 6-month regimen. 6-month regimen is the intervention, and the comparator is the 9th month regimen or 18-month longer regimen. And the outcome is actually a conditional recommendation. Conditional recommendation means healthcare workers can actually take up the recommendation, or they cannot go against the recommendation. And the certainty of the evidence is very low, because maybe the studies that might have added are very high risk of bias studies, or maybe there may be heterogeneity among the studies, or since it is an infectious disease thing, the resistant patterns might be very different among the population. All these things can actually affect the quality of the evidence. But with the very low certainty of the evidence, they have actually arrived at a conditional recommendation. And they have actually the summary of evidence. They have concluded with proper justification and all the evidence summaries. These are all the subgroup, sub-PICO questions and all those things they have. So we can. This is actually the way in which WHO or some NICE guidelines, ASH guidelines, all the Western countries are actually now following this method of guideline making. Only in our country, we are actually very reluctant. Still, we don't have that much of a look for this thing. What we usually do is we always look for West, and we usually adopt that thing for ourselves, and we usually don't go for evidence synthesis. So that's all about evidence-based guideline recommendations. If there is, I think I have finished the thing 20 minutes earlier. Is that a problem? You can have your questions.
Rajesh sir,
Thank
you
you,
there
thank
on-
you, Dr. Jisha, for this
Yeah.
excellent presentation. Now we got few questions from the audience. Let me look at. Okay, we got a question from Mr. Hafiz. What is the scoping review?
Scoping review is actually, it is about the identification of the evidences where they are actually, they do not usually club the data inside the studies. They actually look for what all studies are available, what are the particular populations, where they are actually. So they usually have a bubble diagram, where they actually evidences are more likely to be situated? I mean, what is the availability of the evidence currently are? What are the, how many studies are there for this particular intervention? How many studies are actually available? So all these things comes under the scoping review. Scoping review is not a systematic review. Systematic review is always for the evidence generation, and scoping review is for scope the evidence, where all these evidences are situated. That's what a scoping review is, I think.
Thank you. Now we got another question from Dr. Unikishna Panikar regarding COVID vaccination guidelines. Few concerns about the deaths related to that. So the question is about whether we had a proper guidelines for the COVID-19 vaccination.
We don't. We are actually looking at the randomized. We don't even have a randomized control trial, I would say. We were completely looking at the evidences that were the FDA was actually looking at. Other than that, we were actually recommending for the COVID vaccination, because that was actually giving the unusual deaths are actually because of the particular hypersensitivity reactions, which are actually expected from all the kind of vaccines. But during that particular setting, all these things were quite bulged up.
Okay, so we got another question again from Dr. Unikishna Panikar, is about who is the authority to certify or to say go ahead for the guidelines, especially in countries like India? Do we have such an authority here?
Currently, we don't have a setting for a guideline. But the thing is, a government or authority can actually call upon a steering group, a steering committee. That's what I said about the initial part of my slide. A steering committee is the driving force for a particular guideline. So the steering committee will be inviting the guideline development group and the evidence synthesis group, all these things. So the steering committee is the one who is supposed to drive all these forces. So the steering committee usually should be coming under some ministry part, or it all will come under the authoritative part. Usually in WHO and all, we usually have the technical officers. That's the persons who are actually driving all this guideline related activities.
Thank you. Now from Dr. Jenny Samuel, when you translate the guidelines from or adopt the guidelines from the Western world, what are the challenges you're facing in Indian context?
Yeah, for like I said, the acceptability of the particular thing. Like, for example, you said the thing about the retention enema, or the kind of, for example, like for casirivimab, indavimab, the drug which is actually highly costly. For in patients where a setting like India, where insurance is not that popular, the patients may not be able to afford the drug like Regeneron. But in West and all, it is actually a recommended drug, and based on the guidelines and recommendations, they can actually afford that kind of drug. So when when the government is actually recommending Regeneron, they should also be thinking like whether it is feasible in this particular area.
Thank you. We'll wait for a few more questions from the audience if at all somebody have. Meanwhile, Dr. Jisha, like health equity and the cost effectiveness, how far these items are considered when we develop, especially countries like India, for the guidelines?
For the I mean, like our population is a very vast population, very diverse population. So the thing is acceptable for one kind of population may not be always acceptable for the other kind of population. So it will be equity is all about, like, our social strata is actually very diverse. Sometimes we are the people who have actually implemented the direct observation treatment strategy for TB, because when people are reluctant to take medicine, so when if it is taken in presence of a healthcare worker, then that was effective. So that kind of people will have a lot of kind of, there are for in vaccination, there were actually misbelief regarding the effectiveness of vaccination. So all this kind of very people are actually very different in this country. So one guideline for one particular area is always not possible. So we have to always think about the equity, whether it is feasible, particularly feasible in all the population.
You mean to say the cultural variation will be considered?
Yes, cultural variation very much depend. I mean, sometimes I would like to say, I said about worm infestation. For example, Echinococcus. Echinococcus is something like a worm that is actually situated inside the liver. So a drug like albendazole can actually cure the disease. But sometimes people may feel like, oh, there is actually some worm is actually going inside my liver. I should take it out. So I would be preferring, instead of having this pill, I'm going for a surgery. I want this whole thing taken out of my body. So people can think like that. So there are all kind of beliefs and systems that can actually lead the beliefs of people, that can actually affect the recommendation. You're muted, sir.
Especially since we are working in countries like India. When you say we have set standards and guidelines, what is the response from the physician community now?
I didn't get you once again.
Like, when you set standards and guidelines and you tell the physicians to, go ahead with the guidelines. That means you kind of restricting them from the, some
autonomy. Yes. Sometimes it's like our country is more on, it's more than evidence-based. They are people who are actually believing their own experiences. So I'm actually not against it, but when there are actually evidences, people should always be like evidence-based culture. That something is in a very moderate state. It's not, we cannot say that it's in a high part in our country. It will be more on we are onwards experience based. So that's why sometimes if we feel like our patients prefer more this, then all the guidelines are actually only guiding documents. It's only assisting the healthcare provider to make their decision. It's not like you should do this, you should do not that. It's only guiding. We are strongly recommending it. But if you don't want to take it, it's okay, it's fine. But we are strongly recommending it based on all these things. We are strongly recommending it. That's all about the evidence-based guideline.
Can you give some examples for the guidelines which made some significant impact especially in the Indian community?
Indian community, for example, like the Index TB guideline, which was a Cochrane review, systematic review, they have actually adopted that Index TB guideline for make our TB guidelines. So that's one thing. And I have a personal experience, like during I'm a part of the ICG. So we have actually had this, it's like a collaboration from our private hospital, and we, along with Cochrane, we had this collaboration and all. So we actually made this and we published it in our guidelines. Actually, the Kerala government has adopted that guideline. So for their treatment, Kerala government's treatment guideline for the anticoagulation was, they have actually quoted it as the SIDS recommendation, but SIDS was also a collaborator for that particular guideline. So that means it was actually one of our experience that the Kerala government has adopted one of our guidelines.
Dr. Jisha, actually, we got a lot of students and community from the academia. Let me ask you something. From the beginning itself, you mentioned that it's a totally dry subject. What made you to get into this topic now? I mean, this specialty of evidence-based research. And,
it was actually, for me, it was an on-job learning. It was not like I was particularly interested in this. So for me, if I would say my experience when I was doing my fellowship here, I had the opportunity to review. My course coordinator was Dr. Hannah Alexander. So she usually give me some articles to review and say, what do you think about all these things? And they were actually, when that was the time of, my timing was actually very lucky, that's what I should say. So ICG, at that time, it was a time of infodemic. More than pandemic, it was the time of infodemics. There were a lot of false informations from all of the place. So CMC was particularly looking for treatment guidelines for the hospital. So for that, we actually started making guidelines. Then it actually became a national-wide thing. So that's how I became a guideline, part of a guideline team.
So any advice for the young budding clinical pharmacists, especially for those who are interested to hook their career into ID?
You can career into ID. So ID is actually in every area. ID is actually like many of our hospitals. ID, there is no ID specialty as per se. Most of them for the ID pharmacists will always be collaborating with the infection control department for the AMSP and all. So if you really want to focus your career in ID, I would say there are actually some nice courses in the web, which are actually like the Sanfords and the BSAC, British Society of Antimicrobial Chemotherapy, is actually offering a nice course on this stewardship and all. And if you are so interested, there is actually one fellowship program is actually being run by CMC, but there are only 2 seats, so the number of the competition is quite high. So if you want to, you can always write the entrance examination there, and you can join for a fellowship. And CMC is soon planning to launch a online program in collaboration with SITS as well as IDSA and SHE for the antimicrobial stewardship program for clinical pharmacists for every person. So for all the healthcare workers, so you can actually undergo that training program also.
Thank you so much, Dr. Jisha, for this wonderful presentation and elaborate answers. Do we have any more questions from the audience?
Dr. Jisha, thank you very much for that very vast and detailed presentation. I just have a small question. Is equity an issue when we adopt the guidelines from the West?
Yeah, the equity is actually about, can we give the, can we particularly provide this drug to all the patients? That's the thing that if we are developing a guideline for our hospital, the thing should be, can we give this drug to all the patients who are coming to our hospital? So if it is actually in a Western country, if the government is actually adopting a particular guideline, and that they may be actually a developed country with a lot of finances and a lot of funding, and it will be easier for them to particularly implement intervention. But for a country like India, with the bomb-blasting population and the underfunded healthcare sector, that same intervention cannot be equally distributed to all the population. So that's one thing that actually can actually affect our guidelines. If we actually blindly adopt that kind of guidelines.
Madam, any racial differences, do they cause any challenges?
Racial
experience.
Racial differences, the people I am actually seeing here is mostly Indians as well as Bangladeshis. So other than that, there are not much people I'm saying. So there are not much racial difference in that context, I can say. But I have not experienced any racial differences so far.
Thank you.
Dr. Jisha, you mentioned about the conditional recommendations. Can you just a little bit elaborate on that?
Yeah, conditional recommendation is something like there are actually strong recommendation. I would like to say what is a strong recommendation. Then we can go for conditional recommendation. So strong recommendation is something like, yeah, there are clear-cut benefits are there, and the adverse effects are so bad, and there is a huge evidence that this is very acceptable to all the physicians. All the physicians will be very happy to give this drug to their patients, and the patients are going to be very happy. So that kind of very positive recommendation is the one who will get the status of strong recommendation. Then we are going to be skeptical. Oh, should we recommend it or not? Okay, if we recommend it, they are going to, they are not going to accept this thing. But anyway, the evidences are strongly recommending this thing. So anyway, we have to recommend. So we are saying we are conditionally recommending it, but there are some nits and bits where you can actually overcome this thing. For example, like I told you about the there is actually in our guideline development, ivermectin. There was a drug called ivermectin. So at the initial times, ivermectin was kind of like a magic drug for everyone. We couldn't say no to we couldn't say no to ivermectin because everyone is pro for ivermectin, but the evidences were telling that ivermectin is not good for anything. So finally, we will be like, okay, we are conditionally recommending against ivermectin. Because we are recommending against ivermectin, but it's your choice whether you want to use the particular drug or not. So that's the kind of setting where we will be strongly recommending and conditionally recommending.
Great, thank you. And you really took me to those first couple of weeks of COVID-19 where we had nothing.
Because my experience like in guideline recommendation is actually lies from the COVID, because that's what actually taught me how to do this thing. So that's why.
Thank you. Any more questions? Ramya, can we?
Yes, sir. Yes, sir. Yes. Thank you, Jisha Madam and Rajesh sir, for that informative and interactive session. As a token of appreciation, we would like to share a certificate digitally to our resource person, Jisha Sarajon.
Thank you.
Now, I would like to call upon Dr. Preja Chipillai.
Am I audible?
Yes,
Yeah,
yes,
Preja, you're audible.
Good evening, all. First of all, today's session, I think Dr. Jisha Madam, you made a wonderful session. You have covered all the aspects of evidence-based guidelines and the development, and I think today's session got a clear idea to our participants regarding the process which are involved in the evidence-based guidelines. Thank you, Madam. And I'm here to propose vote of thanks. Thank you is such a prayer that cannot be seen or touched. It must be felt by the heart. It's an honor and a privilege for me to propose a vote of thanks on this occasion. I would like to thank Dr. P.K. Srikumar sir, President, Kerala Pharmacy Graduate Association, for his constant guidance and support in arranging such webinar. Thank you, sir.
Thank you.
I, on
Welcome.
behalf of organizing committee, convey hearty thanks to the resource person, Dr. Jisha Sarajon, clinical pharmacist, CMC, for your valuable session. Thank you, Madam. Next, I would like to take this opportunity to thank Dr. Noble Scaria, Head of Clinical Pharmacy, Apollo Adlex Hospital, for your brief overview of the topic. Thank you, Noble sir. I would like to thank Mrs. Ramya Gayatri, Executive Member for Anchoring Note, and Ms. Namita for invocation. Thank you, both of you. My sincere thanks to Dr. Sujit Verma sir, Executive Member, for welcome address, and Professor Dr. K. Krishnakumar sir and Professor Dr. Shiju Kumar sir, Executive Members of KPGA, for your views and good wishes. Thank you, sirs. Wholeheartedly express my sincere gratitude to Mr. Rajesh Talakaramba, sir, Executive Member, for sharing your valuable thoughts as moderator. Thank you, Rajesh, sir. I am also very much thankful to the patrons and office bearers of KPGA for their constant guidance and support. I feel proud and extend my sincere gratitude to all the honorable delegates who joined us and spared your valuable time to listen the talk. Thank you to all delegates. Once again, thanks to all of you for making this event a successful one. Thank you all.
Thank you,
Thank you,
madam.
Dr. Pooja.
Let's rise for the national anthem.
Jenny is not audible. Ramya?
Silent national anthem. Jenny ma'am, over.
Yeah, I think it's over. But,
There was some technical issue, sir.
Yeah,
It's
yeah.
okay, it's
technical
okay, it's okay.
Anyway, it's okay. Yeah.
Thank you so much, Jenny ma'am, for
So
your
thank
wonderful.
you.
Thanks,
Thank you,
thanks to
Dr.
everyone.
Disha. Thank you, Rajesh ji, and all of the participants.
Dr.
And,
Jisha, thank you very much.
Thank you, sir. Thank you so much.
Good night.
Please
Good
keep in
night.
touch.
Good night to all.
Good
Good
night.
night.
night
Good
to
night,
all.
everyone. Thank you. Thank you so much.
Link for the certificate is shared in the chat box. Sir, can I end the meeting?